Most diabetes doctors don't think that cell transplants work. They think the drugs are worse than having diabetes, but I think they often underestimate how bad diabetes is. And what I've seen in the patients that we've looked after is just stories of transformation.
Hi there, I'm Breakthrough T1D Chief Scientific Officer Dr. Sanjoy Dutta. I have been with the organization for nearly 2 decades and have seen incredible progress towards cures for type 1 diabetes, or as we often say, T1D. Most recently, you've seen a lot of buzz around Eledon's immunosuppression drug, tegoprubart. This particular therapy is used in deceased donor islet transplantation currently, and the results are amazing. 10 of the 12 first participants are already off of insulin. They're doing well. The side effect profile is completely amenable, and it does not have come with the toxicity effects seen with prior transplant medications here. This has been very exciting for the T1D community. I'm here with Dr. Peter Senior. Dr. Senior is the director of the Alberta Diabetes Institute in Canada, and he's been a long-time investigator, transplant biologist, and many others, and a good friend of Breakthrough T1D. I'm very proud to have Dr. Peter Senior here share his wisdom regarding islet transplantation here. And before we jump into that, Peter, thank you for your time today with us. And can you please tell us a little bit about your background and how much experience with the islet transplantation that you can then weigh in on?
Thanks, Sanjoy. Very pleased to be chatting. As you can probably tell from my accent, I'm not from Canada. I moved to Canada in 2002, so it's 24 years ago. And I came to learn about islet transplant, but I must be a slow learner because I'm still here 24 years later. Prior to that, I did my clinical and research training in the UK, where I learned about diabetes and did a Ph.D. And I've been working in clinical islet transplantation and with people with type 1 diabetes for the last 24 years. And Edmonton is home of the so-called Edmonton Protocol, which really launched islet transplantation into a new era. And we're the largest center in the world. We've been transplanting since 1999. And I've looked after more than 330 people with type 1 diabetes who've received islet transplants over that period of time.
Wow, that's very impressive, Peter. I'm talking to the right person. Can you unpack a little bit about deceased donor islet transplants? Why are they only available for adults with T1D? And is that the case around the world, or is that specific to certain geographies?
Yeah, I think whenever people hear about organ transplants and organ donors, I think we always think about shortages because there never are quite enough donors for the people who would need to receive them. So somebody needs to die to donate their pancreas. When we get the pancreas, we'll try and extract all the islet cells that we can, but that's not an efficient process. Maybe half of the time we don't get enough healthy cells from the donor. And many people will need more than one donor to get off insulin. So you're looking at, maybe 4 donors potentially for one patient to be able to discontinue insulin completely. So certainly the shortage of donors, the limited availability of cells, that's a big, big thing. But the main reasons, I guess, why it's limited to adults and a sort of a narrow focus on specific people with type 1 diabetes is because we need to use anti-rejection drugs to protect those cells from the immune system. And essentially, we use the same types of drugs we would use for a heart transplant or for a kidney transplant. And so certainly balancing the risk-benefit ratio is really important. Now, if you have life-threatening heart disease, a heart transplant will be life-saving. And there are some people for whom type 1 diabetes, an islet transplant will be life-saving. But for many people, it's about enhancing quality of life. And so we just need to be careful with thinking about the limited supply and then the risks that we're exposing to people to make sure we make a good choice that makes sense for that individual.
All right, that's very clear here now. So the risk-benefit profile is where we limit it to a narrow swath of people with type 1 diabetes and some other comorbid condition, like we often speak about hypoglycemia unawareness.
Yeah, I think one of the key things is to think, what is an islet transplant good at? And getting people off insulin in the short term is, it's not super easy, but we can do that reliably. But keeping people off insulin forever is much, much harder. And as time goes by, it does seem that the function of the cells does diminish. And so we can reliably give durable protection from hypoglycemia. And so that's very often why we focus on people with recurrent severe hypoglycemia without warning symptoms, because we can reliably deliver for that. And even if somebody's not off insulin, continuously in the longer term, if they, for example, are taking 6 or 10 units of basal insulin once a day, but they've got an A1C that's in target, they're having no hypoglycemia, they can sleep through the night without worrying, that's a durable, beneficial result that we can deliver. Um, and again, making sure that what the patient needs, what the patient wants, what the patient expects, we can actually deliver on. Because type 1 diabetes, as people will know, it's a lifetime condition. We don't need a result for 1 year or for 5 years or for 10 years. We want it for 20, 30, 40, 50 plus years. And that durability has been a big, big challenge, but that's what we want to work towards.
Talk to me about how disease donor islets are classified in other parts of the world. Here in the US, they are classified as drugs versus organs. How are they classified in Canada and in other parts of the world? And does that make the process easier for you?
Yeah, so in most parts of the world, transplants are regulated by one stream. They're regulated as transplanted organs. They're not regulated like drugs or like insulin. And so in Canada, in the UK, in Australia, in Europe, we see islet transplant programs very much like kidney or heart or liver transplant programs. They are relatively small. In Canada, we have 4 programs established, but the Edmonton program, is by far the biggest, maybe by a factor of maybe 10, I would guess. We would do between 30 and 60 procedures per year. The UK is another kind of fairly large center. They've got several centers that work. Similarly, in Italy and in France and Belgium, there are programs, but there are probably only 3 or 4 programs which look after more than 100 patients. So these are really quite small around the world. Um, Now, why is that? Well, organ donation is limited. The expertise to process the cells is, again, hard to learn. It's a skill that takes many years to acquire. And I think potentially there's also a bit of a perception that, well, type 1 diabetes isn't so bad, is it? You just take insulin. There's nothing more that you need. Now, you and I know that that's not true. We want something better, but certainly if you were a kind of hospital, it's not a way you can make money. How would you have enough people? How would you have enough donors? And certainly paving the pathway for a referral stream is work that Breakthrough T1D are supporting that I know. But that gives you a little bit of a bird's eye view. But I would guess that probably worldwide, you might be thinking about, less than 2,000 people. In some parts of the world, islet transplants are really restricted to doing or to being done in people who've already had a kidney transplant. So if you've had a kidney transplant and you're taking anti-rejection drugs already, that really shifts the risk-benefit ratio because the transplant procedure for islets is fairly minor. But again, for most people with type 1 diabetes, they don't want to have a kidney transplant before they can get a cell therapy.
Peter, as you know, we have urged the US Department of Health and Human Services to reclassify deceased donor islet cells as organs. This is a change that can be made now under existing authority. We know that expanding availability of deceased donor islets can increase availability of these transplants. I would love to hear from you on why this is important and how it would increase availability.
I think one of the things that's very striking is that the US is way behind the rest of the world in deceased donor islet transplantation. Currently, the only islet transplants that happen in the US are part of a clinical trial. And clinical trials, as you know, are very, very expensive, and it's very limited as to where those can happen. And if you look at the rest of the world where deceased donor islets are regulated like organs, you see routine clinical islet transplantation in Canada, in the UK, in Europe, and Australia. And so we see reports and studies that show that islet transplantation is leading to better outcomes, to longer life expectancy, to better kidney function. The US has a large donor population. They do lots of kidney transplants, lots of heart transplants. They've led the way in research and clinical care in those other transplant domains. And yet in the islet transplant world, they're seen as being, way, way, way behind in terms of activity levels. And that experience will be really important for clinicians, for insurance companies, and for patients as we anticipate the future where there will be an unlimited source of cells to just have that experience and that confidence to take those forward successfully. Because again, this is something that you learn by doing it. There are no textbooks for this, at least not yet. But this would be a really substantial change so that the US could catch up to the rest of the world and hopefully lead the way into the future.
Yeah, so if I can summarize so far before that, that actually leads very nicely into my next question for you. But so far, it's the benefit risk profile is important for eligibility of who can get it. The other is the technology. People will have to be experts at doing the isolating the islets, and certainly the infusion may not be a very difficult process, but then keeping people off of insulin, and then clearly the availability of donor islets is limited no matter what. It can never meet the supply demand is just an imbalance ratio here. But all that said and done, reclassification by HHS, when that is done, will certainly open the aperture for the number of people eligible to get the transplantation. And we want that. We want that for people. This leads me to my next question, Peter. Last year at a Breakthrough T1D islet cell conference, you gave a very nice talk around this topic about, yes, we can make them available for more people, we can build the expertise around this, but we will never be able to meet the demand here. We need a scalable solution, and that's Breakthrough T1D's North Star goal. Can you, for our audience, can you talk a little bit about what a scalable solution is and what can get us there?
So often we think that being these two big barriers, we need enough cells to transplant as many people as want it. And we need to kind of get over this problem where anti-rejection drugs are sort of potentially so toxic that for some people it doesn't make sense. In terms of addressing this sort of the supply issue of having enough cells to transplant vast number more people than we currently can with deceased donor cells, we're looking at manufactured islets. That's the answer. And so developments in cell biology, understanding what makes cells mature and grow. We've got several companies who have made lab-grown cells, if you like, that are islet cells that can be transplanted into the body like deceased donor islets, and they will make insulin. And they'll make insulin only when the blood sugar is high and not when the blood sugar is low. And they can get people off insulin, as we've done in Edmonton for the last 20 plus years with deceased donor islets. So these lab-grown cells open up huge possibilities. And I've been so excited about this because it's one of these things that's really easy on the back of an envelope to say, we should make cells which make insulin. And, the idea is simple. The execution has been very hard. But again, we're seeing this done consistently by several companies. And that is just hugely exciting in terms of a scalable solution that we can envisage giving to far more people. And again, if you were to ask me, well, how do these cells compare with deceased donor islets? I would say to you, they're brand new. They are new cells which have not served 50 or 60 years service in that previous donor. So we're not repurposing or recycling used parts. These are brand new cells. So they, I think, have the potential to work better, faster, longer than, again, second-hand cells. And again, we can give them in the optimal conditions. The process of brain death, organ procurement, transportation to facility, processing is a really toxic process for the cells. We know lots of them die and don't survive the processing. some of them don't survive the procedure being put into the recipient. And so the cells which last, they're the survivors. But again, if we can do this in a much more controlled fashion where we control the number, we control the size, this is going to be a much more reproducible solution than what we've had to date.
Yeah, and there seems to be a nice confluence of two things here. Where we started today was disease donor islet transplantation with the Eledon stegoprobart drug, which is safe for, at least so far, the data suggests in 18, 19 months, it's safer, less toxic, and people are doing well with it. And so you have an immune regimen or an anti-rejection regimen that seems to be showing, good promise here. We have manufactured islets that we've been supporting. We and others have been supporting for a very long time now. So it seems to be a very nice confluence of events here. Peter, I love hearing you speak here, and your knowledge and the way you communicate these things here. At Breakthrough T1D, we are very focused on scalable solutions that can be curative for people, ideally everyone with type 1 diabetes, all age groups, as long as they need insulin. If we can provide them with these cells in a safe way, protect the cells from being rejected by the body's immune system, that's where we are striving to go there. But that said, we are right now going for the low-hanging fruit. Open up disease donor islet transplantation by reclassifying it as an organ donation, not as a drug. Use safer therapies like tegoprubart, and then while we aim to go for the manufactured islet pathways here. Any last words of wisdom before we end, Peter?
Yeah, just I suppose one thing just to think about, which again, I know we've talked about in the past, but I think getting islet cell therapy as being something which people perceive to be important is really key. And I think if you have reclassification in the US, so we get more experience with deceased donor islets, that's going to be really important for getting the skills of prescribers and doctors treating diabetes to understand, yeah, this is something I can do. Most diabetes doctors don't think that cell transplants work. They think the drugs are worse than having diabetes, but I think they often underestimate how bad diabetes is. And what I've seen in the patients that we've looked after is just stories of transformation. They're able to do the things they want to do, the things that maybe you and I, without diabetes, think we just take for granted. You can go for a walk without planning. You don't need a second purse to bring your diabetes supplies everywhere you go. And I think the ability for a cell therapy to be sort of transformative is one that people with diabetes deserve.
Thank you. That is a bolder Breakthrough T1D is trying to move, is changing the mindset and the psyche of healthcare providers, because that will go a very long way towards making a therapy actually available and utilized by the people with that deserve it so badly here. It's not enough to manufacture it, get it approved, but also to be utilized there. So thank you very much for your time today, Peter. I think I certainly learn a lot every time I speak with you. So thank you very much.
Thanks, Sanjoy.